Good afternoon. Welcome to the symposium, the parallel symposium on implications of gender and disability on perinatal outcomes. This symposium is a parallel session in collaboration with the UNFPA, along with our annual academic session. And I must thank Dr. Ms. Madhu and Sarah for organizing this with a very short notice, and I think we worked within a couple of days to make this happen. So I must thank them. And I would like to warmly welcome the country representative, Ritsuna Kane, and all the other invitees for this session. Let me first introduce Dr. Ritsuna Kane, and she will then lead the session. Ritsuna Kane assumed her position as the UNFPA representative in Sri Lanka as the country director, Sri Lanka and Maldives in February 2017. Prior to this, she was the UNFPA deputy representative in Vietnam. As a passionate international civil servant of UNFPA, she has led a number of policy advocacy initiatives related to population policies, GBV, and youth development. During her 20 years of service with the UN, she also held positions as head of UN Resident Coordinator office in Ethiopia, learning and training specialist at the UN System Staff College in Italy, and UN coordination specialist in the Pacific region based in Fiji. Through these assignments, she contributed to a number of joint UN initiatives. Ritsu has a master's degree in non-profit management from Milano Graduate School of International Affairs, Management and Urban Policy in New York, and a Bachelor of Art degree from the International Christian University in Tokyo. So I would now like to invite Ritsuna Kane to proceed the symposium on disability, the gender and disability on perinatal care. Thank you.
Thank you so much for the kind introduction. Distinguished guests, both online and offline, very good afternoon to you all. It's really my pleasure to be here today as a UNFPA representative on behalf of our office, and the honor to speak to you about this very important issue of perinatal health. And I'd like to really thank the Perinatal Society of Sri Lanka reaching out to us and organizing this symposium in the midst of the pandemic. I hope most of you know that the UNFPA is a UN sexual and reproductive health agency advocating for rights for all for over 50 years. We celebrated our 50th anniversary last year. As an organization which promotes universal access to sexual and reproductive health, the issue of inclusion is very close to our heart, be it about gender, disability, sexual orientation, or HIV status. We work to deliver a world where every pregnancy is wanted, every childbirth is safe, and every young person's potential is fulfilled. And both gender and disability are very much at the center of this mandate. This is also part of the global commitment on the 2030 Agenda for Sustainable Development and leaving no one behind. When we reflect on the history of discourse on gender and disability, we must acknowledge the great stride we made so far in the past decades, particularly on gender equality as we celebrate 25th anniversary of Beijing Conference 25 years ago, as well as the disability rights movement, which led to the many countries ratifying the Convention on the Rights of Persons with Disabilities. So we have come quite some way advocating for these two issues. Having said that, we are all aware that there is so much more to be done to ensure gender disability are effectively and meaningfully integrated in every part of our society. When you talk about the intersections of gender and disability, what we often hear is the double discrimination. On one hand, women and girls are often already vulnerable and struggling in society due to the prevailing discriminations and inequalities. On the other hand, disability is not a gender-neutral experiences, as it impacts women and girls differently, quite significantly differently. Hence the double discrimination. While women and girls have always and will continue to fight for equality and equity, women and girls with disabilities face additional disadvantage due to discriminatory social norms and the people's behavior based on those social norms. Looking at the numbers in Sri Lanka, the last census, 2011 census, indicates 8.7% of Sri Lankan population are people with disabilities. And this is not a small number. And we need to recognize that this includes many different types of disabilities. Very often, for example, people with the mental disabilities is neglected compared to people with the physical disabilities. We need to address these diverse needs and interests. The government of Sri Lanka, of course, has addressed these issues, and Sri Lanka ratified the Convention of Rights of the Persons with Disabilities in February 2016, almost 5 years ago. The country also has a national disability policy, yet the social stigma exists, which could affect how persons with disabilities even access social basic healthcare services. For example, health professionals may hold inaccurate, stereotypical attitude and views towards women and girls with disabilities. For example, about their sexuality, they may consider that they are not sexually active or sometimes overly sexually active. Moreover, due to financial, social, psychological, and other barriers, women and girls with disabilities are often among the most marginalized groups when it comes to sexual and reproductive health information and services. COVID-19, as we are all aware, has made things worse and possibly stalled the progress and the gain made over the past decades. This public health crisis has led authorities around the world to make measures to enforce restrictions on mobility, including physical isolation, to control the spread of the virus. But let's think about how this impacts the people with disabilities, and particularly women and girls with disabilities. I think it became very clear that the gender, disability, and structural inequalities that underpin societies before the crisis has been exacerbated. Women with disabilities who are pregnant are often more at risk with limited or no access to life-saving treatment or care. In a world where access to sexual and reproductive health services are already quite limited for women and girls, pregnant women with disabilities have a greater issue in terms of access and quality of care. This is an area that UNFPA is committed to working on globally and locally. As the lead UN agency on sexual and reproductive health, UNFPA has been supporting the government to ensure everyone has access to sexual and reproductive health services. This also means enhancing access to comprehensive sexuality education and information on family planning, including for people with disabilities. They are crucial to make informed decisions and preventing negative prenatal outcomes. In particular, myths and misconceptions around family planning have to be addressed as a matter of priority. We need everyone's efforts to address this challenge. Healthcare providers and public health midwives must have the knowledge and the skills to provide tailor-made, personalized perinatal care to women with disabilities. Women with disabilities are not automatically considered high risk, but certain medications, mobility limitations, and so on may contribute to high-risk situations. In instances like this, partners and families also have a role to play in understanding the pregnancy and what is required based on the disability of the mother. Men also play a very important role in prenatal, delivery, and postpartum care, and this cannot be emphasized more. The perception that the maternal health is a female duty leads to poor participation of men in sexual reproductive health. Looking at the life cycle approach, especially during her reproductive period, including preconception, pregnancy, delivery, and the postpartum period, the engagement of men are so critical. There's even a study I came across recently which highlights a lack of fathers' involvement in infant care is significantly associated with the intensity of mothers' postpartum depression. Overall, the participation of men during the prenatal period has proven to reduce the rate of preterm birth, low birth weight, restricted fetal growth, neonatal mortality and mother's stress level, and increase the rate of prenatal and postnatal care. This is something that UNFPA has always advocated for. As a society, including men and boys, we must support these reproductive health issues. Through our work, we hope to reach those especially far behind, especially women and girls, and those with disabilities. This has become increasingly important as we race to recover from the ongoing pandemic. Recovery measures must factor in gender and disability. We have a very long way to go, but I'm very certain and hopeful that with the collaboration and partnerships such as this one fostered by the Perinatal Society, we can make a greater stride. I really wish we will have a rich discussion and look forward to continuing our joint work. Thank you so much.
I would now like to invite Ms. Madhu Disanayaka. She is a social anthropologist with more than 15 years of post-qualifying experience and expertise in the area of public policy, social and behavioral changes, communication strategies, public health, gender, human rights, and international relations. She has developed innovative programs, established several community-based networks, and developed capacities of organization, communities, and individual women, youth, and marginalized communities in several countries. 25 years ago, Madhu started her career as a health and science teacher, then worked in the government, non-governmental, and academia in the UK and Sri Lanka. Before she joined UNFP as an assistant representative, she worked as the Director for Public Affairs, Policy and Advocacy at the Family Planning Association of Sri Lanka. I would now like to invite Madhu to the podium. Thank you.
Thank you so much, Dr. Kaushalya. So my task is actually the entire day I was asked to take this task of moderating various sessions, I think. And so how we will do this is because we are aware of the online audience also. We have 3 panelists joining us here, and they will provide their inputs from 3 different areas. I will be reading out their bios, so you would be able to kind of find out from which areas. And then we will open up for the audience to raise questions, because like Ritsu said, the gender and the disability conversations are hard to come by, and we want to start those conversations. The ones that we are finding it difficult to have. So that's why we kind of made this effort today to let's start looking at things that sometimes we miss looking at. And how do we, for UNFPA, like Ritsu said, if every pregnancy is wanted and if every childbirth is safe, if that is what we want to achieve, how do we address that looking at the gender perspective? And when we say gender, most of the time our focus is around women. And when she brought in that men engagement, I was just thinking how important when we talk about gender to realize that we are talking about men also. And it's all right if a man says, oh, I felt my wife's labor pains. He may not physically feel it, but we should be able to talk about it and say that your contribution is valued as well in that right throughout that process. So this conversation is from three different areas to bring in that rich experience, what they have had in their careers, teaching or practicing these in their own fields, and how we can take it to the next level. So first of all, I would like to invite Professor Hemantha Senanayaka, who is a chair professor of obstetrics and gynecology at the University of Colombo. He is a past president of the Sri Lanka College of Obstetricians and Gynecologists and the Perinatal Society of Sri Lanka. He is the current president of the Sri Lanka Endometriosis Association. He's also a member of the Human Rights, Refugees and Violence Against Women Subcommittee of the International Federation of Obstetrics and Gynecology and the Southeast Asia Regional Technical Advisory Group for Women and Children's Health. He's the recipient of 3 presidential awards for research. Professor Senanayaka, over to you.
Um, so I want to thank the Perinatal Society and also the UNFPA for giving me this opportunity of talking about gender issues. So like Madhu said, oh, sorry. Is it you can't hear, or you like to see my face? Okay. 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 So these are discussions we must have, and it's not been happening. So thanks to the UNFPA for opening this topic. So I was given a brief about talking about gender, gender roles in perinatal outcomes, men's role, and perinatal mental issues. So let's take a brief look at disability, because that's one of the things we're going to talk about. So disability has definitions, and but I'm going to start off with a different kind of disability, a case scenario. So here's a woman from the Central Asian country who came to Sri Lanka as a refugee, and I think this is a strange phenomenon for us. It's an unusual situation, and she was able to communicate with us only via her husband, and husband too was not very familiar with the language. It was difficult for him too to communicate with us. And then, to make matters worse, as you know, in government hospitals there are restrictions on visiting hours, and this gentleman would appear sporadically. So to get an interpreter, we were wondering whether we could get one from the embassy, but embassy was also very unhelpful, because this was a person who left that country due to the problems she was having. But she was admitted to us with a very severe renal disease, and in the mid trimester of pregnancy it was a very difficult thing, and it neglected renal disease and hardly any antenatal care. It was a very difficult situation. Really, we had to recommend to terminate that pregnancy, and it was very difficult to go through that. So I'm going to talk again about disability. And if you take the United States, they say 26% of people in the United States, according to the CDC, they are living with one disability or another. They have listed a long list, and it looks like this: problems of vision, movement, thinking, remembering, learning, communicating, hearing, mental health problems, social relationships. It's not entirely, does not entirely include the example that I gave, but we saw that as a major disability for that woman to be able to communicate with us, and I think that kind of situation, people get marginalized in our hospitals. I have just retired from the D'Souza, and I've used to work with people from Colombo 10 rather deprived areas, and very often we used to come across particularly Muslim women who couldn't speak in Sinhala. Okay, and I know the response from many grades of staff to this situation, where this woman was told, you are living in Colombo, you better learn Sinhala. But in her environment, it was not necessary to communicate. I like to talk about people with, say, a good example is hearing disability, coming to have babies in hospitals in Sri Lanka. To what extent are we going to help these people? Very often, fortunately, they come with a family member or a friend or somebody from that their immediate social circle who can communicate with us and use sign language to communicate with her. So these are real problems that we come across, and in our government setting or even in a private setting, we might not have any kind of mechanism to cater to that kind of situation. So really, I don't think there are reliable statistics for disability in Sri Lanka. If the US is 26%, I don't think we will be much further down. So we have problems that we are not really looking at, we are not seeing them, but the problem is there. So the gender, we keep hearing that it's not binary. You have the sex, which is very different to gender. Sex, we tend to think as a binary issue, either you're a man or a woman, but really it's not that simple. You can have, even at a genetic level, people who are not really man or woman. Phenotypically not man or woman, it's complicated. But gender is different. It's a social construct. It's a different thing in different places, even within the same country, even within the same community. The roles are very different depending on their inputs and influences. So here's another area we really don't know about. What do Sri Lankan men want to do when it comes to childbirth? Okay, so if you go to a first world country, the men's roles are fairly well established. People want to get involved, and they want to be very much a part of it. Do Sri Lankan men want to do that? Do the husbands want to get involved like this? I want you to ask yourself that question. So again, I have been talking a lot about this in different fora. Birth is a time for joy and celebration, but in our government setting, we are denying our people of this joy, that moment of birth. I have been delivering babies for a long time, and I very often, when I show the baby to the mother, I look at the mother's face, and that look on the face I can't define. It's a very special thing. Think about the time you had babies, and that moment is very special. But we are denying our own people this. But in a private setting, it's very different. Here is in a private hospital. This lady has just delivered the baby, And, you know, she has both her husband and the mother with her. So I've been encouraging, and I think this is more or less the norm in the private sector now. Earlier it was not so. We even get the husband in as a standard now for a cesarean section as well. So when you compare the private and the public sectors, now there is a major inequity. There is no equity at all. That the same woman who was going to deliver in a government hospital, if she finds the money and comes to a private hospital, that same obstetrician will be allowing all these things. So I think we need to think about these things. I think it's not right. Now I have been encouraging this, and I have experienced Sri Lankan men of all strata, of all educational standards, of all ethnicities, of all religions. And I can say a lot of these men really want to be involved and be part of this. So this is something we need to look at. I think it's very important. Men want to get involved. So there are other questions that can come out of it. Will that improve the bond between the man and the woman in a Sri Lankan setting, in this extended family? Will it reduce gender-based violence? Will it reduce postnatal depression? So these are all questions we must ask, and I think we need to strive, we need to stride into these areas. So, again, like I was saying, in the private sector, the man being there is almost the norm. But what about the public sector? This is from my own ward. We have 30 inches between two beds. I've shown this picture time and again, but we still managed to get a woman, a female companion into the labor room, and we had no problems with this. You can see this laboring mother's mother seated there. We have just enough room to get a little chair in, and we still managed to do it. We've been doing it for the past 10 years. When we started, people were saying, okay, you will start getting complaints now about how the patients are being, the mothers are being looked after. But we have a big file, and we stopped collecting those letters as well. A big file where people are thanking us and praising us for starting this, and these came at that time. So what about the men? Can we get them involved? So these are my thoughts, and this is not research based or anything like that, but these are my thoughts. Our men are excluded by the system and the society. But many men will be aware that in a different setting, a first world country, the man will be there at the time of birth. People will be aware of it, at least the people who have had some kind of exposure or education. Like I said before, I've been very concerned about it because there is robust evidence to say that just the mere presence of a female companion will improve outcomes. It will shorten the labor. It will reduce the pain relief required for the woman. It will reduce the cesarean section rates. Cesarean section rates in Sri Lanka, is higher than US now. We are about number 15 in the world rankings of the sections, and it's still rising year on year. And then here's an intervention that can reduce cesarean section rates. I really can't understand why aren't we doing that. We've shown that it can be done. I know there are some of my trainees, they have started it in their places, but sometimes when they move, the person who comes there will stop it. That has happened. So it's a sad situation. Here's another thing. No, I had this experience. I want to share this as well. That's in the last year that I worked in the DMH before I retired. We had a woman who was a diabetic. She came, but she had been told to get admitted for. She came to us late, but unfortunately, she had a death in utero. The baby had died inside the mother. After all that effort of looking after her diabetes, etc. Right? So it's traumatizing even for us, and we can only imagine what it is for the mother and the family. So when we just made inquiries as to why she couldn't come, she said she didn't understand the instructions that were given. So I asked my colleagues, what if there was somebody else with her? Why is it that our women have to come unaccompanied to our clinics, for goodness sake? Because we can give a much better service, more humane service, if we are allowing somebody else to come. So in my last year, I said, when you're coming to the clinic, because there is hardly any privacy issue, because we get a nice cubicle now in the Disoisa to see our ladies. So I said, okay, we will allow the woman to bring in a partner or anybody. So in fact, women came in with their husbands, sometimes accompanied by their children. So these were totally different experiences for our people, but they really appreciated it. And I can tell you, over 95% of those people would have walked out of my room smiling. They were very happy because we could explain, they could ask questions. But these are things which are very simple interventions that we could, get more participation from the men, understand the problems that the women are having. I think we should move in there. So this is my question. But what about paternity leave? My own experience was, I still remember when I was doing this murderous job called, murderous means I got murdered as registrar of obstetrics and gynecology, which is a very busy job, and I had this little kid, few days, and then 2 o'clock in the morning I am burping the baby and having to go to work in the next day, work about 16 hours. It was terrible. I think we need to think about paternity leave. We are talking about our human development index. I think we need to think about these things. It's important, and I think that will help the family to bond, man to understand what the woman is going through. So here's another thing: if you have participation, this is something you can avoid. These are all the papers that were published in 2018 on violence during birth. Okay, there's a lot of violence during birth, and this is from many countries, and there is one paper from Sri Lanka as well. So these are the things that, and then also that has an effect on perinatal mental health as well. I came across a woman who had such a traumatic experience in one of her previous pregnancies, and she had told her husband, if you're going somewhere, don't even take me past that hospital. She wouldn't even want to go that way. So these can be very deeply emotional experiences, negative experiences for women. So we need to talk about perinatal mental health, and I'm very pleased to say the Perinatal Society put out this book, and I also contributed to this. This was during the COVID time, when we thought perinatal mental health might be even more important than before. So we put out this book about maternal mental health on all 3 languages. In lay language, it's a lovely little book. Right. One of my young colleagues did a study on a bunch of women who had babies, and he found PTSD, post-traumatic stress disorder. It's like the soldiers going to the front and sleeping through all these artillery fire and everything. Mothers experience that. So 16% is the figure that's given in Sri Lanka in sporadic studies on mental health issues in the perinatal period. So it's exacerbated by the gender-based violence, and next year, I think very soon, I think the document is out, the women's well-being study done by in Sri Lanka, done by the Department of Census and Statistics, I think, and also the UNFPA supported that, and that shows gender-based violence is there in a fair way. Okay, so these are the things that our mothers experience. Poverty is there, although we are. So in a way, in medical care, Sri Lanka is like a land of no other, isn't it? Because we are no more a poor country, like we were talking yesterday. We are no more a poor country, middle income country, but we are stuck in a 1950s mindset and a poor country mindset. Doctors, when they go to buy their cars, they say, okay, how many settings, presets does the driver's seat have? But when it comes to giving care, it's a different story. Right? So poverty, stress, and a difficult birth, and also one of my young colleagues, Mohammed Rishad, is doing a study on patient experiences, client experiences. He's doing an MPhil. It's an extensive study. We have some Italian partners as well joining us in that. It's going to be a very good study about women's experiences during birth, and it's really revealing how hurt they end up and things like that. And then in the Disoiza, we look after a lot of minorities, particularly the Muslim women, and then what they have to go through is quite surprising, and at the hands of care providers. You know, so I really want to leave you with all these thoughts, and I think we can expand on this during the discussion. So once again, thank you for your patient hearing, and thank you, Madhu, for opening this, and also this topic, really difficult one, and the Perinatal Society. Thank you very much.
Okay, so thank you so much, Professor Hemantha. I think instead of asking Professor Subangi to come in, I thought of inviting Dr. Jan Mendis, because we sort of, we can start from where you stopped. Because once again we said perinatal mental health, and I would like to so Dr. Jan Mendis is a psychiatrist, and currently he serves as a lecturer in the Sir John Kothalavala Defence University. He was the director of the National Institute of Mental Health in Angoda. He was also the former president of the Sri Lanka College of Psychiatrists. Dr. Mendis did his postgraduate training in University of Psychiatry. Right. So thank you so much for joining us, Dr. Mendis. Over to you.
Thank you very much. Thank you for inviting me. In fact, Professor Hemantha Senanayaka has been my AOG while I was doing my internship in Castle Street Hospital. That is way back in 1986. I also initially wanted to do gin and ops, but the way how women were treated, I tell you, I have not told this that much. The way how the women were being treated, especially in Castle Street, as well as in Gaul, not the Karapitia, the Mahamodara Hospital. I thought that it's really women were undergoing those days. Mahamodara, of course, with all due respect to whoever, the family health workers and all, they used to use filth at the time of delivery of mothers, and usually the statements have been very, very, in fact I started to hear most of the filth at the labor rooms. Then you could remember or you could understand the the difficulties what the ladies were undergoing at the time of deliveries. And those days, other than St. Michael's and very few private hospitals in Colombo, no other hospitals were also developed. Even in Castle Street, I could remember we have been discussing about transferring our patients, those who are going to labor, in our ward itself. Can you remember that corner part of the ward? Because we felt that even after delivery it takes long time, hours for the epis to be sutured and various complications. Then after that I went to Angoda for my post-intern appointment. Then I settled down there. I will start with the finally a question. In mental health we set for these final year students from KDU this time. A 22-year-old female was referred to a mental health unit by the gynecological team for psychological assessment and further advice and support. She is unmarried and carrying a pregnancy of 20 weeks. You see, we may not have question during our days. These kind of questions from medical students. But nowadays, this is a common scenario. Now, yesterday, I saw a lady was brought, in fact referred, patient is from Hambantota, and the VOG has said that you are carrying a 20-year-old fetus, but she doesn't have, a baby doesn't have a head or anencephaly. And they wanted to take a second opinion, and they had come to Castle Street, and a scan was performed, anencephaly was confirmed. Then this lady was not talking, not eating for 2-3 days, and weeping, and this is her second pregnancy. And she was brought to me in Navalok. And you see all, and when she carries a baby, what she was telling me was that I am going to carry this for nothing. You need to have a lot of skills to manage this kind of situation. 5 minutes spending with the patient, or even 15 minutes spending with the patient, is not really enough. And I offered her for admission to a gynecological or medical ward, mainly to perform somewhat a longer counseling, at least for her to come to terms with this. Then this is about implications of gender and disability on perinatal outcome. Professor Senanayaka covered some part of my aspect also. This is also a common sight where we see a lot of ladies when they are pregnant. They do a lot of labor work. It is now even I have seen that in factories they work a lot of labor work, not the white collared work, and in my presentation, I'm just going to discuss about the issues and the poverty, then access, availability of services, availability of skilled services, caring, medical attention and attention by healthcare providers, and using of language. You see, this DMH, Castle Street, all those hospitals, lot of ladies are coming with various physical complaints that they have to face as a result of pregnancy. And most of these physical disorders or physical issues has huge component of psychological element. But do we really have time to spend time with asking other than their main medical complications or medical issues? And you see, pregnancy itself, maybe some percentage will experience happiness, but another percentage will have feelings of ambivalence, whether to go ahead with this pregnancy or not. Is it an appropriate pregnancy or not? Sometimes they are more worried about them having unwanted pregnancy. In Sri Lanka is also one of the country, even though the abortions are not legally permissible, there is a huge place for abortions in Sri Lanka. You name a city, that city has more than 100, 120 places where they perform abortions. And as a result of abortion, they have to undergo various kind of psychological stressors. But we don't address those issues. I told you about pregnancy related disorders, and lot of, not like those days, nowadays they come across various kind of medical disorders, and that will become only the disorder per se than the person or the full picture. We don't get into context. And various kind of problems happening to the fetus, uncertainties as a result of the fetus or the baby undergoing various problems. The mothers or the parents, they have to undergo various psychological issues. Then the family issues. You see, even though the country has developed, we have 1950 mentality. That's what Professor Hemantha Senanayake said. Yes. Then the partner, on the partner's responses, now of course is changing a lot. And then the attitude towards the pregnancy, attitude towards the females, then the financial aspect, interrelationship issues, the mother-in-law issues, other family members, you see, and all these are also complicating the pregnancy and the puerperal. Then lot of issues relating to delivery. We of course had the privilege of staying with the partner, since we are a privileged kind of people, because we had the chance to stay with the partner. But what percentage of other partners could stay? I don't think that even in present context, I don't know, it's allowed now in DMH, the partner to be with the, no. We have been discussing about these things in 1986, you see. Still, everything are in the discussion stage, not carrying on. And then the psychological issues, maternity blues. Lot of healthcare workers, they don't recognize maternity blues or this changing of emotions immediately after delivery. The larger percentage of pregnancies or the deliveries will undergo maternity blues, about 80%. And the healthcare workers usually interpret it to the problem of the patient. And they, as a result, I come across lot of patients with postpartum depression, comments in the way how these healthcare workers responding to maternity blues. Thereby they start to undergo various kind of anxieties. Then the depression, of course, is about 10% of the deliveries will undergo depression, and the psychosis, mood disorders, and the maternal suicide. You see, when he was the chairman of the obstetric college, we started to think about to preventing maternal suicide, and that is one of the easiest way to reduce maternal death rate in Sri Lanka. All the other causes, I don't think that we can do much. Cardiac causes, respiratory causes, isn't it? But maternal suicide rate could be reduced to a maximum. And the death of the baby, when a death happens, there has to be, you need to have a grief counseling, and we need to allow them to undergo that grief, and we don't know whether we are allowing that kind of space for the patients or not. Yes. Then the postpartum complications. Then the occupation and mental health is also, occupation, mental health and postpartum period is also a huge area where it is also unrecognized. When you start having children and they may not be able to perform well, as a result of them not performing, they will start to experience various kind of stresses at workplace. Then this group of disabled, I don't know whether DMH or other Castle Street has a disabled access even. If a mother is disabled, we don't know whether we have think of that kind of aspect of improvement. And the various kind of disabilities, physical disabilities. Then Professor Senanayaka was talking about you were talking about double stigma. When a mother is mentally ill and having other problems like ordinary pregnancy, it's going to be triple stigma. It's going to be triple stigma. And what the partners used to say is Pissugani. This is Pissugani means it is due to she is having psychological complications, and as a result of pregnancy and delivery. Then the long-term mental illness, and when they become pregnant, and they also have to undergo various difficulties, disabilities. I don't know whether we have a space for that kind of uh, um, kind of people. It's about 10% of the population is having various kind of disabilities, and whether we give that much of time or chance for them. And how do we improve the care in service provision? And we have done 2-3 things. One is, now Angada Hospital, those days when a mother give a birth to a child, the child is transferred to LRH, the mother will be admitted to Angada Hospital, and that is the end of that marriage. When I was a medical officer, what I used to do was to mainly to trying to counsel the marriage for the partner to come back to the marriage. Then I decided that when I had the chance to have a mother-baby care unit in Angada, this is a 8-bedded unit with an attached toilet, and where the partner also can come and stay with the patient, and the partner, he can bring if he has any other children as well. And this is one way of improvement, and thereafter most of the psychiatric units in the country now has at least has one room for mothers and babies. And to prevent suicide, and mainly we have introduced Edinburgh postnatal depression scale to all pregnant mothers, but unfortunately this won't be analyzed by the treating team or mental health treating team. And this is number 2. And number 2 is that with Professor Senanayaka's initiation, we could manage to introduce this psychological autopsy tool for maternal suicide. Every year, about 30 maternal suicides happen. For last 3 years, 80 maternal suicides had happened, and now we have analyzed all those 80 suicides, and in the process of presenting our data. And this psychological autopsy tool go into the deep aspect of patients' interactions and the involvement for us to understand the reason for not to prevent the particular suicide. Thank you very much.
Thank you so much. Thank you so much, Dr. Jan. In the interest of time, let me quickly introduce Professor Subangi, our last speaker. She's a professor in sociology at the Department of Sociology, University of Colombo, and has been serving as at the university for the last 35 years. She obtained her PhD in sociology in 1997 from University of Waterloo, Canada, on a Canadian Commonwealth scholarship specializing in gender studies. She also received the British Commonwealth Postdoctoral Fellowship in 2004. She was the key person in developing social work studies in the Department of Sociology in 2008. She has served as a consultant in large number of governmental and non-governmental institutions in the country and has taught in several universities abroad. Over to you, Professor Subangi.
Thank you very much. Thank you for inviting me for this event. I'd like to thank UNFPA team for the invitation extended to me. I have been doing quite a lot of research studies on gender disability, but not particularly on this topic, perinatal care. But in most of my studies, it is so difficult for us to completely, you know, not to include aspects of maternity and issues related to mothers and children. So in my studies, I have come across issues that two of the previous speakers have talked about quite often, and I'm trying to bring those into my presentation in the way we can within the given time period. Now, one of the most important aspects is that it is so difficult for us to isolate motherhood or pregnancy or child care from the rest of the arenas in the life of an individual or a family, right? So when we talk about society, these are everyday life events. We cannot really look at anything going on in our lives according to how we see the society today, anything going in the life of people in isolation. So there are many cross-cutting elements, many intersectionalities, as we call it now, to look at. So childbirth, perinatal care is essentially one of them. So one thing we know today, unlike maybe 10, 20 years ago, childbirth and related requirements are universal, and we have accepted the need to be looking after mothers, no matter who they are, where they come from, what level, socio-economic level they are in, which country they are from. So it is a universal acceptance. But needs of the mother and the child during and after pregnancy could be something quite different from these universal standards as we see it, because what women would expect from the society. It is just like other gender issues. Sometimes when we talk about violence against women, during my research, women have said that yes, I go through difficulties, but I am living with my husband and I have to live with him because I don't have any other alternatives. He is the only income earner. Because of that, don't interfere into it. Even though I was doing research, don't talk about it, especially in front of my husband. I am ready to go through it because there is no other way. So pregnancy related issues and maternity related issues are also very similar. Sometimes they could be satisfied with very little opportunities, very little resources, but they would no way come to the international universal standards, but they are still happy. So my first question is that how do we measure this? Are we going to stay with the very minimal needs of the people who say that this is all I need, I just can survive with this? Or do we have to try and do something to change the picture and achieve a higher goal? Right? The problem is mainly really due to cultural differences, socioeconomic differences that cut across many of our everyday life issues. When it comes to issues related to perinatal care, I have to say pregnancy and childbirth is not always a reason for happiness and celebration. And especially when we look at the Sri Lankan context, we know a child is a precious resource that we have, and we all talk about the importance of having a child. That child is so much precious in our culture. But is it common for everybody? For some, it could be a shock, a pain, a dilemma, a worry, a pregnancy. Then we also think we have this cultural understanding that pregnancy is a matter related to women alone. Before and after pregnancy, issues of support and companionship is not always there because it's still seen in certain contexts as a woman's issue. It is up to woman. Right? My question there is, does leaving no one behind principle universally applies? It doesn't, we know. What is the situation of vulnerable populations in perinatal care? Right? So when you say vulnerable populations, I'm not only concentrating on gender and disability, but also social class issues, ethnic issues, religious issues, and so on. So there are many. Now, when we look at motherhood, it's a social cultural concept. For many, in the field of healthcare, it might be a biological issue. I'm not saying they are not concerned about the motherhood as a social cultural matter, but there are socio-cultural interpretations of motherhood. Who is a good mother? So there are standards adopted by many different cultures in different ways about the good mother concept. Who is a good mother? And can a woman in the present context live according to the good mother concept and the cultural expectations involved in that? So high level of tolerance, and this is a very, very interesting point I always come across in my research. When it's a girl is considered as weak, sometimes need to be taken care of, soft, all those different traits that we attribute to a girl. But when this girl turns into a mother and a wife, very often, we expect the strongest, her to be the strongest person in the world. So she has to have a high level of tolerance. I'm not saying tolerance is a bad thing. I always say that 100% tolerance, if you can develop with regard to everything that you face in your life, it's much better. But what is the interpretation of tolerance within our culture? How far we can complain about certain things, right? Then contentment. A mother has to be contented, not expected to complain about pregnancy-related difficulties. I think Dr. Mendes also mentioned about the treatment in the healthcare sector, and I have lots of stories with regard to that. Then normalcy, this concept of normal. Pregnancy is normal. Every woman is going through it. So you can't have, every woman is facing this, so you also have to face it in the same way. We don't see individuals as different, and these different individuals would face certain situations differently. So pregnancy and maternity is one of them. So we don't see it. All women go through it, so you are also one of them. That the idea of normalcy. Then comparison. This is one other issue women face during their pregnancies and childbirth. Pregnancy between past and present. The women in the past, our mothers, our grandmothers faced it this way, so why can't you? So this is another issue women face. But the life of the woman today is very different. 50 years ago, the life of a woman was different. She was surrounded by extended family. She was surrounded by the community. She was supported by the community. Family was much bigger. So she had a lot of help. But today it's very different. So we tend to care, we tend to compare between the past and the present, or with another woman. That woman who is coming from such a background faced her pregnancy in such a way, so that why can't you, why can't she, right? So this not allowing individual differences, and as we heard now, people are different, mental conditions are different, the way people face the reality, face their everyday life situations is also different. So we don't allow that difference even in the perinatal period. So I also would like to say a few things about family and social roles in pregnancy and childhood care, although it was already discussed. The problem here is that we still tend to see pregnancy as related to the woman, and mother is the sole responsibility of child care. She is giving birth, so it's her responsibility. Although we have been talking about gender equality for so many years, at least I have been involved in this field for the last 30 years, and we always expect that the things would change in the near future, but no, it hasn't changed in the way we want. Right? So still we consider the child is the responsibility of the mother. It was at least 78 years ago, the sociologists talked about the importance of collaboration, joint effort within the family, family as a shared unit, sharing of a life together, sharing of sexuality together, sharing of childbirth together, sharing of the socialization process together, sharing of a house unit together, a place for dwelling, right, together. But still, we consider pregnancy and childbirth as the responsibility of the mother. You need support. So it is, the role is not, father's role and mother's roles are very clearly separated, and father is in a supporting role, not really taking it up as his own role, right? There are fathers who are really very willing to, but even those are not really allowed in many occasions. I can give you an example, although time is limited, that I came across a situation where the mother-in-law, the mother of the husband, came home to visit the baby after the baby was born, and she noticed that her son is really taking a lot of care about the child, and even to the level of bathing the child in his own. So two of them were there and they were really sharing. And the mother got very angry and she prohibited the son to do it. This is in Kurunegala. In one of my studies, I came across this event. The mother prohibited her son, and mother just said that you are a man, you are not a woman. Woman is not supposed to do this. She went to the point that not to help in the kitchen. I mean, she also asked the man not to help in the kitchen. Then I asked her, mother-in-law was there when I went there, so I asked her why then she said, a man is not supposed to, in our family circle, man is not supposed to touch the spoon. So I asked, which spoon? Kitchen spoon. Kitchen spoon is not allowed. The table spoon you can handle. So the woman has to serve on the table the food, and then the man can eat it, but don't cook simply. Don't get involved in kitchen work. So this is a mess, and there were a lot of problems after that in the family, and that's a separate story. So these attitudes are still prevailing in the society. Right? Pregnancy is again a woman's matter, and she has to face it. Work and double day is her choice. This is something that I heard from men. Work, I have not asked her to work. Taking up a working role and facing a double day of work, that's home and outside, public and private, that is her choice. I haven't asked. So if we choose to work, then she will have to learn to manage both at the same time. So support and involvement of male partner is there, but again as a supporting role, there are occasions in certain levels, both at the lower level, both at the low economic levels and high economic levels, where some men choose to support the woman during this period, but it's not a must, right? It's not a must, but for the woman, it is her job, part of her work. And also there is a very clear, I think Professor Senanayak also talked about this exclusion of men from the process, the cultural exclusion of men from the process. And the gender-based violence issue also was touched, and this is a very serious issue. I came across a situation in an upper middle class family about 15 years ago, where the couple, the woman was pregnant, and the couple was coming down from the stairs arguing with each other, and at one point he stopped and kicked the woman, and she fell from the stairs, and later I found that she died. The baby was taken through a surgery, so baby was alive. And when I talked to the family, the mother-in-law said, my son is not a bad person. My son is not a person who would kill a person, or, you can't level charges against him, because he's a very caring child, my son. So he just kicked her. He just kicked her. This was her words. And just one gesture of violence could be very critical. It could be life-threatening, and we still don't see it as it is. Right? And also fading of traditional support systems. That's another issue that is coming in here. That do women today have these traditional support systems they used to have earlier, community help, extended family help, and so on. So social class and the access to resources is also a very important matter here, because not all pregnant women, not all women after birth are having access to same kind of resources. One thing, private sector healthcare and public sector healthcare. And I'm not saying public sector healthcare is bad in this country, and we have been able to achieve lot of high standards, similar to European or developed levels, because of the quality of public sector healthcare and free health factor, just like free education factor change the entire country. But at the same time, we know many issues that are there, and how still in the public sector health, especially these maternity related issues that Dr. Mendes mentioned, so many women have revealed their personal experiences to me, that how they are ill-treated there, how badly they were, verbally treated, filthy language that has been used, and so on. So it's not a pleasant experience for the mother. And there was a woman once told me that for a second child, I want another child, but I am saving money little by little because of the bad experience I had to go through in the hospital, government hospital. For the next childbirth, I am thinking of going to a private hospital because I can't take it anymore. Right? So this kind of issues. Then the nature of work, Dr. Jan Mendis also pointed out, the nature of work women are doing, very heavy work sometimes. You have no other choice, right? You have to support the family. Some women, until the last day of delivery, the day of delivery, they are working in the field, in the construction, in various heavy work, and not all women are having this luxury of taking leave and staying home before the childbirth. Then norms regarding food and nutrition. There are ethnic and religious differences in this, but that is another very important aspect. I would like to narrate this very small story that once I was doing another study in the Eastern Province. I went to a house, a very small house, a tiny house. A woman pregnant woman came out of the house holding another small baby. So she was pregnant and she had one small child. And inside the house there was this huge plate of rice served on the table. I could see the entire house when I was standing at the door. This huge plate of rice. And in another small dish, there were some yams. So I told her, I knew that she has not eaten. I told her, why don't you have your meal? I will go to the other house and come back. She said, no, don't go. She forced me to stay. And then she said, no, this is not for me. This is for my husband. She would come back from work now, from the field. If she would get very angry if I don't have his plate of rice served on the table. So she had a small amount of yams. She is waiting for her other older daughter to come back from school to eat that. Then I asked, what are you going to eat? No, my daughter will not eat so much, so I can have some of it. Right? So then later we got quite, I could build a good rapport with her. And then she told me what kind of difficulties she had gone through. If even a little rice she couldn't save to cook for her husband. And we know pregnant women are treated very well in village communities. People say that we are supporting them. If we are giving food, we are giving for 2 people, not 1 person. So it's considered as a meritorial deed by villagers. Even in cities they do that still. But there are occasions where they are very badly treated. But in some part of Trincomalee, where there was a Tamil community, entirely Tamil community, I was told that their way of serving food is first older people, then if there are pregnant women, them, and children, and then the others in the family. So that in that village, they told me way of serving food is different. So it is sometimes ethnic, religious, cultural and so on, but quite often women's nutrition, women's food needs are not looked at even during their pregnancies. They will be ill-treated with regard to food. And also, as pregnancy and perinatal period usually is considered part of nature. And there are pros and cons about it. Excessive medicalization could be avoided through this, because for every little thing, every cough, every little cold, we are now doing that, but we don't, women didn't used to seek medical care, specialized medical care because of that. But at the same time, every difficulty, every pain, every change in their body, women think, or the others in the family think it's related to pregnancy. So because of that, they go unattended. And that could lead to very serious issues. That's considering as part of nature. Sometimes could lead to some difficulties. Right? The disability aspect also very, very important. The gender is very similar to gender aspect, and disability and gender are also cross-cutting elements. When it is a woman with a disability, it's even more difficult, because disability very often is considered by the society as as a condition of total inactivity. We even don't call a disabled person a person with a disability. There is a big difference in that. When you call a person a disabled person and a person with a disability. A person with a disability could have a particular disability, but in all other aspects in his or her life, he or she would be normal. I don't even like this word normal, right? Like any other person, right? But when you see people as disabled people, you think that he or she would not have other very common human needs, other drives, that is coming that are usually within people. So sexuality is very often a total prohibition by the society, total prohibition for people with disabilities. So we don't consider them as human, we don't consider them as having urges, needs, and so we think always how this person is going to give birth, take care of a child, and because of that, this is not a good thing, that a woman with a disability giving birth. Right? But at the same time, the other side of it is that women with disabilities are very often are very often subjected to violence. On one hand, we are saying that sexuality is not for them, pregnancy is not good, but on the other hand, we are lot of rape, teenage pregnancies, unmarried mothers, these problems are there. So it's a very, I would say, hypocrisy that is there in the society. On one hand, they are considered as having difficulties. On the other hand, they are at your use whenever you want. So it's very important that we have to have a right-based approach with regard to sexuality and child birth rights of people, pregnancy rights. So we don't have lack of social support systems in place. And I think I have mentioned this term before, that this term is very often used now. We are living in an architecturally apartheid environment, right? Because we have created a physical environment for people without particular disabilities. And then we say they don't fit in here. The people with disabilities don't fit in here. Is it their fault or our fault? Right? So we didn't see that. We didn't see that people with disabilities as part of our population. An anthropologist, Margaret Mead, in 1920s said American population, we cannot talk about American population without talking about the disability. Without talking about the people with disabilities. They are also part of the population. Just like all ethnic groups belong to our population. All religious groups, all cultural groups belong here. And similarly, people with different psychological conditions, different mental conditions, different physical conditions, whether it is intellectual disabilities or mental disabilities or physical disabilities, they belong here. So it is our responsibility to construct the physical conditions of a society according to that, taking that into consideration. So I think that is very important in the hospital context, that we think of women with disabilities in perinatal care. So question is here, is the society ready? to accept that and to
Prof.
work
Subangi.
towards, yes,
If you-
work towards it. So is the health sector equipped, right? So that is the main issue that we need to talk about. Healthcare sector is not free from gendered norms and attitudes. So we also have to take that into consideration, and that is the end of my presentation. Thank you.
Thank you so much. So I would like to ask from the audience first, if they have, Dr. Subangi, would you like to join us here? If you would like to pose any questions after hearing our three expert panelists, yes, over to you, Niluka. I can, is there another microphone? No, the online audience is there.
Okay. Has this been switched on? Okay, fantastic. So actually,
Just
right.
introduce yourself as well. It would be-
Okay. So I'm Niluka Gunawardana. I am a visiting lecturer at the University of Caledonia and a consultant at the University of Colombo. And looking at me, you can also see that I'm a woman with a disability. And I actually really wanted to thank all the three speakers for the general overview that you have given us today. And I actually wanted to make a small comment. So in my case, I was born as a child with disabilities to my mother. And when I look at her experience, firstly, one of isolation. Secondly, one of blame around karmic lines, that it's her bad karma that I was born like this. And also then, I mean, I am in my 30s now. Even now, if I go to meet a doctor with my mother, I've had instances where the doctors go, "Oh, were you taking antibiotics when you were pregnant? Is that why your child doesn't have, you know, a left forearm?" So in terms of those kind of perpetuation of those very negative ideologies, it's quite damaging for mothers. I also work quite a lot with parents of children with disabilities. That's actually a mothers group, right? And the overwhelming feeling for those mothers is grief. Because at the point of birth, right, I know for my mom, she had to write to her friends abroad, get journal articles, because there was no real sense of what is my life with a child with disabilities, no kind of awareness raising, no kind of support provided to her at that point. And that's why I think when we talk about perinatal care, right, and perinatal rights, we need to look at what are we offering to parents, you know, whose child may be born with a disability or whose child might acquire even a disability. That's not part of the perinatal framework, but it's really important, right? And so the thing is, it's natural, I think, if a child is born with a disability, for a mother to grieve, because, you know, their idea of what the child is has changed. But the fact that they're still grieving 15, 16 years into, you know, having this kid itself shows that we have really kind of missed out on providing that support. So I think we then also need to look at how do we portray disability. Like I know when I was little, in terms of role models, right? Can she go on to get an education, get a job? Like all those discourses around disability need to kind of be brought into the picture. And so I wanted to highlight that point because I think it's a really persistent issue, especially for mothers, given the, you know, care disparity that Professor spoke about that exists here, and also in terms of gender and disability, motherhood, the rolelessness that we have in our society. And again, it needs to come from the broader systemic thinking around disability. So just wanted to point that out.
Thank you so much. Would anybody wants to respond, or is there?
Yeah, actually, you raised a, thanks for bringing on that personal perspective to this. But I really think, as a medical educator, my time is gone, but I really think we should take a more rights-based approach, and I saw the phrase being used in Subangi's presentation. We need to look at, recognize the rights, and I believe that's been a failure in our system. And also empathy, you know, we have not failed to teach that, and that is exactly what your mother experienced, and this grieving process being prolonged because of the insensitivity of the people. And if a doctor is not going to give it, who's going to give it? You know. So I think these are, and I've been trying to point this out to my colleagues. We are teaching skills, but I think these are the skills that are more important. You know, somebody comes with a cough or something. You know, even if you give the wrong medicine, you know, unless it's a dangerous thing, they will still get through. But some of these other things are more scarring. You know, I think we need to be more cognizant of that.
Yeah, those are called soft skills. In fact, during our time, the medical students, medical schools may not have even paid attention to these soft skills. And if the causes for five causes of any condition is asked, we need to answer according to the way how it was mentioned in the book. Otherwise, the boss used to do like this. Then the one, when if I say the third one, then he will still raise the second finger up. But now gradually the medical education is also changing, and most of the students are also being taught about these soft skills, how to do this consultation. We have never been taught how to do a consultation, isn't it? And how to, but we have been taught about MRI, CT brains and all the features, everything, but not the ones that usually day to day important for consultations and the other instances.
Yeah, just to add to that, actually at University of California, we've started an elective on disability sensitization for medical students. So hopefully the future outcome will be better.
I'm Dr. Sujata Samarakon. I'm a venereologist, so we take care of women who have HIV during pregnancy. But let me throw a little positive light where most of our medical students and our doctors have been trained how to deal with this kind of sensitive issues. If I recall the 1980s that Professor Mendis was referring to, we also as HIV physicians had the same problem, to which Hemanta is evidence, where a pregnant woman who is HIV infected had a lot of difficulties to face, especially in the health sector. But gradually it has declined. If anybody is challenging that, let me also hear their views. But personally I know that lots of HIV positive women are not subjected to that kind of discrimination today when they are pregnant or even otherwise. And that had to take a lot of a big journey where the medical students, the consultants, the patient themselves had to be groomed to live with this fact and how to face it. And most of the gynecologists, the pediatricians, they worked very cordially with us, and we also got that partnership very well established. So we need to get our health system geared. We can't just sit and wait. Now Professor Mendis said from 1980s we are talking, Dr. Hemanta and I, we are talking. But what have we achieved? So we are all in our retirement age, but I think we still can do something very positive to the society. So we can't let things just continue. So we have to make a change somewhere, and wherever possible, I think even now we can get together with even people like UNFPA and Perinatal Society and try to do something to bring light to these lives. Thank you.
Yeah, actually, I remember those days when patients were being refused care on the basis of a HIV test, you know, and I remember when Professor Sharifdeen started doing those abscesses and things like that. In people with HIV, nurses used to walk out. Even in Castle Street, we had some time, and then I think the key to success was the collaboration, like you mentioned, and then proper training of staff and creating the awareness. And I mean, nowadays, woman with an HIV, HIV retroviral positive woman would deliver and go, and the woman in the next bed wouldn't know. I mean, it's so smooth now. So,
No, the same thing with with any patient is positive with COVID and a psychiatric illness or other illnesses. They also have to undergo various kind of stressors in the present context. But this might, in fact, it was more earlier part of the pandemic, but now much less.
yeah, about the conversations we used to have, but I think we've achieved something in institutionalizing, allowing a female companion. Now there is during labor. Now there is even a government circular which is encouraging it. So we've not only talked, we've done something.
No, and I can guarantee, I think even Dr. Manoj might be able to tell us from Family Health Bureau. Dr. Chitramali was supposed to be here. From next year's budget, if I'm not wrong, or in the coming years, we are increasing that 30 inches area to a much more bigger area, so that the delivery what I was told was that we will have curtains drawn across so that a companion would be able to stay, so that kind of decisions are being made. So I think, whatever the efforts or discussions that you all have made, now we are taking it forward. This discussion happened very recently, and I asked what is our next step, and this was told at that meeting. So let's hope that, women and the partners will get the opportunity to be in the same room in that situation. Yeah. Yes. Anybody else? Ritsu, would you like to?
I just wanted to build on your comment and the issue of sort of, how do I put it? I think it's a holistic well-being. And it's not just about the issue of empathy and being kind to someone or your patient, but it's about ethics for me. Because medicine is not just about lack of disease, just treating disease, but really helping patients' well-being. So in that perspective, if that's the ethical approach to the occupation of medicine, I think it's a very integral part of services, the health services and health care. And I know that the doctors are very much in line with that kind of thinking, but very often we still see some doctors seeing the role of doctors just treating disease. And I think we need to go beyond that. And for that, I think, as you were mentioning, it's important to have a very holistic perspective, and it's so nice to have Dr. Sabangi here that, sociology has a lot to contribute to medicine, and also anthropology has a lot to contribute to medicine. So I think this kind of very holistic, cross-sectoral approach to health is really needed in the next generation of medicine. Thank you.
Thank you, Ritsu. Yes, Kasanjit.
Hi, my name is Kasanjit. I'm from UNDP. Just wanted to raise, actually with the 16 days of activism happening very recently, we had a dedicated session for persons with disabilities, more or less women with disabilities. In that segment, there was a very enlightening or eye-opening situation came to light, where the women with disabilities are never one from one end they are not uh, educated about their right of having their sexual, how to sort of, sorry, oops, how to sort of have the sexual rights and what their rights are actually to whether they are entitled to have a baby or not, because a lot of parents are saying that even marriage and have, being a mother is not beyond your capacity, and there has been a lot of issues like that, and apart from that there was other issues like uh, whether they have the proper knowledge of how to sort of deal with a child, because especially because of the lack of sign language interpretation, the hearing impaired colleagues have lot of issues in terms of understanding what a doctor or midwife would give like the advice. It's very difficult for them to understand that. So we'll have to definitely take that into consideration, because otherwise there will be a lot of issues in bringing up the child. And it's very important that you give if you have a person with a child with a disability in the family, it's very important the family counseling happens, because it affects the family, because of the situation with the society. We need to give family counseling, otherwise there won't be there won't be empowered person with disability coming out, because lot of negative mindsets will make uh, the mother or the father or the family suffer from psychosocial disabilities itself, because of that issue, that child being there. And just wanted to bring those things out as well, especially after birth. There should be some way of addressing those issues as well. Thank you very much.
Thank you.
Yeah, I think say one of the commonest things we come across in that context is the birth of a Down syndrome baby, you know, and we don't have a formal screening program or whatever, and then also this issue of termination of pregnancy comes in, and then we find that we are poorly equipped and the family is not equipped at all. It's so this, like you said, the social counseling is a very important thing. We talked about, in my talk I talked about a woman who lost her baby, right? Now we have established a service for them called the Rosebud service, where we have trained nurses in counseling and they deal with these people, and it's very successful. And I'm glad that some of the other colleagues are also wanting to implement that in their hospitals. So I think we have a long way to go in that as well, particularly the children with disabilities being born, and how to deal with the other children in that family, those. Thank you.
Yeah, I think the issue you raised about communication, it's so important because you can imagine with the people who are using sign language, whether it is possible for them to communicate to a doctor or any other medical, in the people in the health sector of their issues, because we don't have that facility available in the sector. And already people are having so much difficulties because of the language issue, because during my studies in the Eastern Province, people who were not speaking Sinhalese in Kantali sometimes had to go 80 kilometers to Trincomalee Hospital in order to get medical support, because they couldn't explain their illness. There were no doctors available who are speaking in Tamil in particular areas. So when language is a problem, you can imagine the level of problems people who are using sign language face. So I think I agree that there is a long way to go in developing these needs in the health sector.
Um, it's from Desiree, and she's the chairperson of the Family Planning Association, and she's asking, now I have been a sexual and reproductive health and rights activist for almost 5 years now. My question is, what can we as young activists do to bring these issues to light, to make sure that generations to come will not face these issues that the panelists spoke about? Would the panelists be able to say something, and then, you can provide your last words at the same time. So, over to you.
Yeah, I think most important is accepting the drawbacks. I think start from there. What are the, because probably I don't know whether more research is needed, because there are experts who have been working in the field for so long, who have recognized the problems, who know the problems. We know the problems now, so act from there. So I think we have to plan properly, address issues one by one, and prevent people in the future, young women in the future, will not face the same difficulties their mothers and grandmothers faced. I think that is the only way I see. First, accept that there are gender issues, there are disability issues. Not all people are the same, not all pregnant mothers are the same. They are not enjoying the same benefits, same opportunities when it comes to pregnancy and motherhood and all that. So I think see that what while we are doing one part of it, still continuing to raise gender awareness and social awareness of these situations. The health sector also has a role to play. I think address issues one by one, identify the issues, and go ahead.
Yeah, I think my answer is that to sum up, really, the things what we had seen in the past has changed, and certain things are changing. Certain things might not change that quickly, and what I believe is that keep on trying to change will someday will come to a light.
Yeah, thank you. Actually, Jan, you said some things that I wanted to say as well. You had to keep sort of change is a constant thing, and we have to keep striving for that. And the answer to the question that was asked is, I think it's very important to create awareness. And a lot of these violations of these problems, and then the system not being equipped to handle these questions, is because the lack of sensitivity, not because people are bad or cruel or whatever. People have to be sensitized, and I think from young activists, if you can, as a young activist, if you can keep creating awareness, that will be, a very positive thing. You need to create awareness. But I'm really delighted to hear that the government is going to invest in this better labor care and looking at the psychological aspects of it. So thanks very much, and I think it's a very good initiative, this, to bring out all these hitherto unaddressed events things, and we've had some useful things coming out of this session. Thank you.
Thank you so much. Thank you so much to the panelists for this very insightful discussion. I think we have to start from somewhere. So we've, at the beginning of this year, I think at the ICBD conference, we had an initial conversation. Our work is actually looking at inclusivity and making sure we leave no one behind. So in order for us to achieve the 2030 goals, we always say that it's very, very important we leave no one behind. And I know that all of us in our own ways are trying our level best. So I would like to end by saying, just like every one of you said, yeah, be the change that you want to be, you want to see, like Mahatma Gandhi said, we can do that if we put our minds to it. And I think all of them have tried to bring out all those aspects that we are now experiencing as a change. So thank you so much for participating in this conversation, and I hope that we will continue to do so and will follow. Thank you so much.